Hi everyone, I'm Claire.
And I'm Ben.
And we are Your Dental Besties.
Making dentistry fun.
I wasn't ready then. I was like, oh God. Oh dear. So I had someone Instagram, well, they actually Instagrammed the Your Dental Besties page, which is randomly on my iPad. And I know that sounds really...
Who uses Instagram on the iPad?
It's because I've
It's
got...
the most awful interface ever.
I know it really is, but I don't know. Well, I reckon I could probably work it out, but like, I'm worried about like logging out of my profiles because I don't know the passwords to get back in.
Yeah, but I don't understand. Why does that make you need to use it on the iPad?
Just because it's on there all the time then, and I've got 2 on my phone, and then can you have like more than 2 now on your...
Yeah.
Oh. Well, if I can remember my password, I'll put it on my phone, and then I'll probably post a lot more on the Your Dental. Have you just done an inward yawn?
I actually haven't.
Oh, it looked like you did. You
No.
pulled an inward yawn face.
Oh, what are you?
If I can remember my password and everything, if I have it on my phone, I'll actually post on there more often because I never carry my iPad around, which is why the Your Dental Besties Instagram is like dead as a donut. I need to actually post on there more often.
Yeah. You need to let me have access to it.
I know. Well, if I knew the password.
Is this your OCD why you don't want me to have access to it?
No, and I need to send you the passwords for YouTube as well because I just can't. I can't do everything, Ben. You're going to have to take over some of it. And you do want to. It's just me sending you the passwords. It's my fault. It's my fault entirely. Anyway, long story short, someone sent me a message with an agony uncle, and I'm going to just try and do it from memory.
Okay.
See if we can do it. So long story short, they are at a practice where they've been doing GBT on every patient and they love it. And they're getting a new hygienist in. And this new hygienist is going to be working on the same day as them. And they only have one machine. Yeah, so there's one day where it kind of overlaps, but they've only got one machine. What does she do? What happens? She's like, she doesn't want to give up her machine because she really enjoys using it.
No, don't think that she should either. I think if she's the one that's kind of implemented it in the practice and built it up, then if the practice wants to get more hygiene, because I'm assuming it's off the back of her doing work in a really good model, then that's the time that they need to invest because that one hygiene day is going to turn into 2, it'll turn into 3, it'll turn into 4 and 5. So that's the only real solution that I can think of. If there's 2 units, then what is the practice where is the worried about, oh, we're going to spend this much money and it's only for an extra day? I
think that there's like no talk of investing in another one so that they can have 2 running on like one day. So it'd be a lot for like just one day's sort of work, I guess. I don't know. I mean, you can still work off the principles of biofilm control always comes first. It's just going to increase, you're probably going to use the test drive for longer, for example. So you can still work off the principle. Like if a patient's booked in with one hygienist and then the other, they might not be getting like the airflow and the warm water and everything, but you could still be following that same principle of like disclose, remove the biofilm using the test drive, and then remove the hard deposits. So that subliminal message is still the same. Like biofilm comes first. It's all about resetting the button with biofilm removal. But yeah, it's difficult but then I think it was like, do they charge less for not having...
No, they're making a rod for their own back. You got new hygienists come in. If they're like, oh, well, you can continue using the GBT machine, but she's or he is going to now just do normal, traditional modality, we'll charge less. The patients... Honestly, I think if they've had the GBT and you go back to it, you'll be like, no. But some patients will just be like, well, I just want to pay less money.
Yeah, they will. And I think, like you say, I think you're doing yourself a disservice. And it's, let's face it, like traditional modalities do still get patients to health if it's done in the right way. Yes, it's not as minimally invasive. It might not be as comfortable. But then what you're going to learn from that is when the patients go, no, I'd rather wait and see the other hygienist. Well, then it shows you that it's worth that investment to get the next machine. Because patients are like, well, I want to, I'll pay the same, but I want the warm water.
But if you get that thing that EMS has just brought out, £390 a week. A month, sorry. £390 a month, yeah. £390 a month. That, again, what did we work it out to? So that hygienist on that day has to make £100 extra profit. That's not that much money. And if the hygienist does 2 days a week, then that's 50 quid a day. Like extra that they're going to have to find on top of the fee.
Yeah.
If they put the fees up generally across the board, £2, then that's going to pay for the extra GBT unit, and everyone's going to be happy. They're going to be able to work how they want to work. The patients are going to be happy. The hygienists are going to be happy because they're not fighting over a machine. It's just about working it out, actually. So maybe that's something that the hygienist could do. Actually,
forward.
Yeah. So let's think £390 is the figure that we have to get to. How much would we have to increase the patient fee to add on there? You don't want to obviously do like, let's just add £20 on to everyone's fee, but it's not going to be £20. It literally will be like £1 or £2.
Yeah.
And it might mean that if you're on a percentage base, then that kind of will somewhat be sacrificed because obviously this money's gone, but it's not massive amounts of money.
Now's the time to do it. I don't know what, April seems to be when prices change anyway, don't they? So if you're going to put it up by £1 or £2, then now's the time. I mean, this is different because that's a second unit for 1 day a week, right? But do you know what I always find really baffling is, when people go and buy like an iTero or like a scanner that costs like 30 grand, they don't think of return of investment.
No.
But then when it comes
when are you ever going to be like, I'm so glad I saved 30 pence on that alginate. I'm so glad I bought this 40 grand iTero scanner. Yeah. Like, it's not...
It doesn't... That same conversation isn't had, but you want to buy something for the hygiene department so that the patients have a better experience. It's easier for the hygienist to do a meticulous job. Like, it's less invasive on the tissues because we want to be minimally invasive as a practice. We're a high-end practice, so the experience should be better for the patient. They're paying good money for a good experience, but we don't want to... We're not going to, if we consider that equipment, we need to see that return ASAP. We need to see that, like, get us a return of investment. But I'll buy this iTero for 30 grand.
They don't pay anything for 6 months.
Well, you could, yeah.
So if that hygienist was working with that GPT unit for the first 6 months, 1 day a week, it would pay for the bulk of it.
Yeah.
Just think all the profit that's going to be made from them, and then put it towards the GPT unit. Easy. And we know the fact that it's 1 extra day. It's not going to be 1 extra day.
No. If they do things right and they do things well, it'll be more.
Yeah, it'll turn to 2, it'll turn to 3, it'll turn to 4.
Yeah, if they've got the space for that.
Yeah.
Yeah, but they should, hopefully, because you need to have less dentists with a wider ratio of hygienists.
Yeah, well, if you are health prevention and you've got a stable patient base, I think that's the way forward.
Yeah.
Things will change. Because we have already seen it. It's starting to happen now. The dentist's diaries are so quiet, so they're starting to take hygiene visits and put them in my book.
That has happened to a person that's got in touch with me recently.
We've seen it a lot. Well, yeah, the dentists are kind of getting quieter because of prevention. Like, not everyone's going to need a restoration.
Do you think people are like buckling up as well, like because prices are going up with like fuel and blah, blah, blah. So people are starting to buckle up, and so this cosmetic dentistry boom is kind of going to slow down?
I don't think so. I think if you want something, and you value it, then you'll get it. And I think patients are the same. Like, if they really value something, then they'll just make sacrifices somewhere else. It might be that they might not go on 3 holidays a year, they might go on 1 and then invest more in their health. We see it all the time. Like, some patients will be like, I know, just can't afford it. And then you look outside and they get into like a new Porsche, and you're like, well, you can, but just
they're choosing not to.
Yeah, you're choosing not to, and that's fine. That's your choice. But it's just where you value spending your money.
Yeah.
So I do think that, and I do think things will change, and I think dentistry will change, and I'm hoping the ratios training of hygienists and therapists, the dentists, will change.
Yeah. So when I'm going into the universities, what I'm finding is, this is generalising, you've got 15 to maybe 30 max hygienists and therapists, 80 dentists. Yeah. So is that what you're seeing?
Yeah, because they get a lot more funding for a dental student, like 10 times more funding for a dental student than what you do for a hygiene and therapy student, which is wrong. There's apparently no more money to increase that funding, and then the dental kind of courses don't want to sacrifice any of their money to bump up the hygiene therapy. But it goes back to the age-old problem of prevention doesn't pay. People don't pay notice until there's an issue. And then it costs 10 times more to resolve the issue. Yeah. Whereas if they just paid in the first place for prevention, and I think we talked about it a few podcast episodes ago about the Nordic countries. They're very prevention heavy. There's loads of like public health campaigns and stuff. But that's what you want as a nation. You want a healthy nation. You don't want diseased nation. Then you're spending loads of money on maintaining the health.
Yeah.
Prevent disease.
I was speaking to a dentist, actually. She was in BDS. And she came over to speak to me and she was like, I was a hygienist therapist and I've gone to BDS. I was like, oh, good for you. That's fantastic. What made you make that decision? And she was like, I hated being a therapist because I knew my worth, but I was just not valued at all. And I want to be a dentist because I want to be valued in what I do. I was like, that makes me really, really sad. Did you really feel like that? And she was like, yeah, no one ever listened to me. And she was like, so I've had to go to the extremes of like thinking, right, well, if I'm wanting to be valued in dentistry, I need to be a dentist. And I was like, well, I really hope you enjoy dentistry, being a dentist, because it's sad to hear you didn't enjoy it being a therapist. But she was like, I'm just really interested in prevention. Like I love prevention. I loved being a hygienist. It just wasn't the job for me because of the value that was placed on it. And I was just like, I could see, can you imagine going back to dental school and then like working to be a perio specialist just because you needed to be a dentist so you were valued, but you like perio so much that you're like,
yeah, if I went back and done dentistry, I'd end up being a periodontist.
Yeah, I'm the same, yeah. Because I love it. I love it. So I'd want to do it. I wouldn't. There's so many things. I don't choose to be a hygienist because I'm not good enough to be anything else, right? When I left the army, I thought, well, obviously I've got to go and top up and be a therapist. But I consciously made the choice not to because at the time it was just in like NHS, it was like children and, it wasn't as well paid because you were working in the NHS. So I was like, why would I go and do a course that would give me less money when I qualify? However, I also believe had I been a therapist or if I was a therapist now, my brain is just not, I just don't think I'm restoratively driven. I'm definitely health driven. Like I am all about systemic health. And I think even if I was a therapist today, I would be working to my hygienist scope and really excelling in that because I'd be like, I love the systemic health side of things. I love the subject matter expert I am in being a hygienist. So if I know I could go and be a therapist and I know that I could potentially go and be a dentist, but there's so many things in those two jobs that just don't suit me as a person. And I want to be subject matter expert health. I love it.
I don't want to deal with dentures. I don't want to deal with root canals.
Yeah.
I wouldn't mind the restorative side of things, but the other stuff, I'd be like, no.
Yeah, I'm exactly the same. Actually, I've got an interesting thing. I've been talking a lot about dentures to students. Like, I'm going to take you on a different tangent here. This is like slapping you with a fish. This is like a totally different tangent. So I've been talking about this a lot when I go into the universities and I'll say like, just a little thing at the end. Dentures, do you talk about it with patients? And usually the reason we don't talk about it with patients is because we want our appointments to be a nice experience. And often dentures comes with a lot of shame and regret, especially if it's around disease. Obviously trauma, that's going to be something else because that we can't help that. If you fall and knock your teeth out, you fall and knock your teeth out, right? But if you've had perio or caries and you could have done something different to not let that happen, there must be an element of shame and regret. And we know that's the case because so many patients don't tell their partners they've got dentures. So there's going to be that element. So I don't want my patient to be reminded of that in my appointment. So I'll clean the dentures and I will be like, how's everything? Everything okay? Yeah. Glide over it a little bit. And then, and if they take it out their mouth and it's absolutely caked in like adhesive, I'll be like, let's talk a little bit about how to place the adhesive on a little bit better because less is more in this case. Like the minute you're putting way too much on. And that's when I would talk about it. But we're in a preventative job, right? And what we do is we wait until the denture doesn't fit anymore before we start thinking about adhesive and fixative. It's in the name, isn't it? Adhesive, fixative, Fixadent, So we wait until it doesn't fit till we start talking about adhesive. And then we do it in a way where we're accepting that the denture maybe isn't performing as well. And so we need to now add something else to the sort of the mix. We don't think about it when it comes to food getting trapped underneath the denture. And I always say, like, if you had a stone in your shoe, and you were walking down the street, you would take your shoe off and take the stone out, wouldn't you? Because it's flipping annoying and it rubs and it's not comfortable. So you take your shoe off, you get the stone out, and then you continue with your day. But if you've got food trapped underneath your denture, which I imagine is a lot more of a pain in the arse than a stone in your shoe because the mouth's so sensitive, there's so many nerves, it must be really uncomfortable. You can't just whip your denture out and like clean it, like get rid of whatever's on there and then put your denture back in. So you've got to kind of put up with it until it's socially acceptable, like when you're on your own somewhere and no one can see you. But if you wear an adhesive, you're going to prevent the food getting trapped underneath, and you're going to stop the movement. So you're going to prevent rubbing because, again, like we say, we're in a preventative industry. We don't want to have someone come to us with sores. We can prevent those sores by preventing the movement. We can allow the denture to perform better, so better biting force. And I've started saying to patients things like this: do you ever not eat certain things? Like if you went out with your friends, do you avoid certain things in the menu? And often they'll say to you, well, yeah, like I'm never going to eat the steak. You're never going to
corn on the cob.
Never going to eat the corn on the cob. So they are, in their terms of their quality of life, they're avoiding things. Like they're not living the best life because they've got something that's holding them back. But if they had something like a fixative that works well for them, then we can allow them to live that quality of life. And then I also stand there in front of like the students and I'll say, if I was stood in front of you today doing this lecture, and I was wearing a denture, I imagine that in the back of my mind, all I think about is I hope my teeth don't fall out. I hope my teeth don't fall out. Am I performing my best if I'm thinking that as I'm speaking to you today? And they'll be like, no. And I'll be like, okay, so I'll go even further than that. Would I be stood in front of you today if I thought that that was a problem? Would I even put myself in a position where I was in a job which caused me to have to do public speaking? And they're like, yeah, you probably wouldn't choose that job. So now my job's affected by the fact I've got a denture in. But the one thing we can do is to add to that performance and give them the confidence and the quality of life and the self-esteem is just by getting them to use an adhesive properly and well, a good quality one, and say, this is to just give you quality of life, better confidence, better performance. We don't want you to have sore tissues because you're a perimenopausal, menopausal woman that's got tissue atrophy and the tissues are getting thinner and now things are going to start rubbing. Let's not get there. Let's prevent it.
So you're saying that you put adhesive on a denture regardless?
Yeah, that's the thought process. Like preventative, doing it as a preventative to things like soreness, things getting trapped underneath, which can be a pain in the bum and not be, we've all had a patient take the denture out and it's caked in food. Ugh, yeah. It must not be comfortable and it's going to smell and all things like that. But if we use something that's going to stop food from getting trapped underneath, because if we show them how to put it on, I like the really thin nozzled denture adhesives because you can put like precise placement. Because I think patients think if you cake it in it, it's going to, work better. But actually, if you cake the denture in denture adhesive, you're actually going to prevent like that suction, increase exactly that. Yeah, so you're not going to get that sort of hold. So precise placement, thin nozzle. You're going to prevent food from getting trapped underneath. You're going to prevent the movement of the denture. Now think about retained teeth. If they're periodontally involved, we don't want something pressing up and moving up against all of that. So we're going to prevent that a little bit. So that's also going to have a knock-on effect with the sort of their remaining teeth. But also from just a performance point of view, we want you to eat the apple. I want you to be able to live the life you want. I want you to go on a date and not have to think about what's on that menu because just in case your teeth fall out. Go on the date and eat what you want. Go and get the job public speaking because you're not having to worry about it.
It must be awful to have that in the back of your mind.
Yeah. I wouldn't put myself... I mean, hats off to people that do, but I imagine I personally feel like I would think about it enough and worry about it enough, especially if it was an upper, that I would not put myself into positions, and people probably often do, not put themselves in those positions. And I just feel like... So now I talk about it because I think I might be the only person that they actually talk about it openly and with no shame.
I do think there's a thing about people who wear dentures where you're just like, well, you've lost your teeth. It's like, do you know, in terms of priority pile within dentistry, it's like, well,
you're there, so you obviously don't care. So, but that's like, not the case.
I know, it is really sad. And a lot of the time it's because that was just the done deal. Like, that's what happened. The dentist just took my teeth out. I don't really know why.
There might be of that generation where that happened. You know, where it was like, there seems to be a generation where everyone's got like very heavy fillings.
Yeah, heavy metal.
The heavy metal generation. And then you've got like the tooth loss generation where it was just like teeth were whipped out. And they're the ones that obviously we all thought that it was inevitable you're going to lose teeth. But now we know more. Like, imagine the shame of it now where you're like, I probably didn't have to go through all of that back then if I'd have just gone to the right dentist, or if it was like nowadays, that wouldn't have happened. And you know what? Sometimes the people that do the best work, that get the best outcomes, are the ones where it's like advanced disease and it almost gives them the kick up the arse. So actually, they might become your healthiest patients because they're like, I don't want this to happen to any more of my teeth. And we know that once you start going down that path, it probably is going to happen to more. So we need to work with them harder, not let them kind of get on with it, or not. We don't let things get on with it, but like almost write them off. But yeah. Again, it comes back to having the difficult conversations, being comfortable in the uncomfortable conversation. Yes, dentures might be an uncomfortable conversation because you're going to bring those feelings of potential shame or regret to the patient, but normalize it with them. Like, that was then, this is now. We're not there anymore, and we're not going to lose anymore.
That was quite informative. Thank you.
I'd like to give.
Denture Diaries with Claire.
Denture Diaries with Claire, yeah. I just think it's not something I ever was like massively passionate about before, but I just think, do you know what? So like, I have to talk about it, or it'll be obviously own fix it. And it was when I started thinking like down that kind of, in that kind of way, I was like, wow, I probably have, not had those conversations when I should have.
It's not really something that we talk about though.
Yeah. Well, you can now at university. You can talk about it with your year threes.
Yeah. No, I will.
Amazing. Well, great. Well, we hope you enjoyed this episode. If you did, please do like, comment and share. And we'll see you again next week. Bye.